introduction.
All right, well, hello everyone and welcome. Thanks for being here today. I'm Evan Ardeel. I'm a first year faculty here at Western, and this is my first time engaging with the Honors College, and it's been a real treat. So for me, I would say this project really kicked off in the winter term in BNS 302, which is a course that I teach about neuroscience research methods and communications. And as part of this class, Ava did a presentation or a series of presentations telling us a really fascinating story about increased susceptibility of women to multiple sclerosis and what we might do about that. And so after the class, we all learned a lot. And after the class, when she suggested that she was interested in exploring this topic further, and it's different areas of neuroscience, I was really keen to learn more as well. And so we decided to kick off this honors capstone project in the spring term. And this is really her brainchild. And so I'm going to just hand it off to her. And I'm really looking forward to the presentation, Ava. So please join me in welcoming Ava.
Yeah, thank you. Yeah, this is definitely a variety of all of my mixed interests smashed into one presentation and one project just for fun. So yeah, I decided to kind of take the information I was learning about neuroscience in multiple sclerosis and other autoimmune diseases and apply that to an illness called Ehlers Danlos Syndrome, which we'll get into on the second half of this presentation. So yeah, today I'm mainly going to be presenting on the ways in which our current knowledge and treatment practices in the medical field are currently underserving women's health in particular, but ultimately all our health. So yeah, in my time here at Western, I've been able to find more and more intersections between all of my interests in human health, in history, neuroscience research, and women's health issues. And so neuroscience has been a really big contributor in deepening our understanding of the links between our nervous system and all the other systems of our bodies, from our mental health to immune systems, hormones, inflammation pathways. All of these things are connected and are not currently addressed as a group in healthcare. They're usually tried to address in separate categories, which I'll talk about in a moment. So at the end of this presentation, I'm hoping you'll have a deeper understanding of how important women's health research is, some flaws in our current medical system maybe, and also learn about some key examples of complex diseases that also happen to predominantly impact women. So Western medicine, understanding how all the systems of the body interact, like between nervous system, immune system, etc., are particularly relevant with complex health issues because they involve multiple body systems, they have super wide ranges of symptoms, and these conditions have proven both hard to identify and hard to treat in the past, but largely due to the organizational setup of our healthcare system. So for as long as we've had modern medicine, the body systems have always been treated in isolation from each other. And as we learn more, it becomes clearer and clearer that that's just not really how our bodies operate. So anyone who's maybe dealt with complex health issues probably knows the feeling of being passed around from specialist to specialist, told you don't really fit into anyone's lane. And this comes at great cost, both emotionally, financially to the patient, but also to everyone else working in the medical system. And so this, in my opinion, is a big issue that needs to be addressed if we want to prevent more patients from falling between the cracks in between medical specialties. So this healthcare system has also historically informed how we're viewing the human body, and therefore we weren't always able to understand or treat complex issues the way we probably should be able to, but now we're able to see them with a fuller picture and have more and more tools to do that. So in the past, things like hormones were believed to have no more impact than on fertility, but we now know that hormonal patterns play a huge role in the development of neurodegenerative diseases, for example, or brain health. We now know that the ovaries are directly innervated by fibers of the sympathetic nervous system, so they're actually a neural organ. And most issues involving women's bodies are understudied, still pretty mysterious, and that's not super surprising considering that only 3% of neuroscience studies are focused on women's health. So yeah, we're in kind of a desperate need of a rebrand, in my opinion, if we want to treat people effectively. So I thought it would be fun to start out if I just present a few examples of why studying women's healthcare alongside men's health is pretty critical, and in some ways where the past has had some pretty significant consequences because we've failed to look at women's health issues accurately. So starting out with autoimmune diseases, let's take lupus, for example. The current average diagnosis time for lupus is 6 years, but many patients have reported as long as like 40 years to get diagnosed. And this is one of those complex, very hard to identify illnesses sometimes, but it also disproportionately impacts women by a 9-to-1 ratio. So 90% of lupus patients are women. And then 63% of lupus patients also reported being misdiagnosed with something else before actually receiving an accurate diagnosis. And then the rates of lupus might seem inordinately high, but out of everyone in the US with an autoimmune disease, 78% are women in general. And for another example of those with MS, 75%. So clearly we're looking at something happening here that might involve women's health issues if we're looking at all of these women developing autoimmune diseases at such a higher rate than the rest of people. Another example, with pharmaceutical drug trials, women also tend to have statistically higher rates of increased severity and increased rates of adverse drug reactions compared to men, but less surprising when we take into account that most drug research is carried out on male subjects. So women's menstrual cycles are often believed to complicate and muddle the data, so they don't want to have them in research trials, but then it's assumed that our bodies will react the same to those medications, which doesn't really make sense. And so for one example, with schizophrenia here, current treatment guidelines are not taking into account these sex differences. So the current like standard practice treatment is high doses of antipsychotic medications, but we already know from more recent research that women don't receive the same clinical benefit from high doses of antipsychotics, but they still receive them as first-line treatment. And phase 1 clinical trials, which are drug trials or for other treatment practices, only have usually around 20% female participants. And it wasn't even until 1991 that the first long-term nationwide study of health conditions affecting postmenopausal females in the US was carried out, called Women's Health Initiative. And that was thanks to our first female NIH director, also appointed in 1991, Dr. Bernadine Healy. And it was only 2 years later, in 1993, that the NIH inclusion policy was written into federal law, which is the law requiring women and minorities to be included in research. All right, this is fun. So hysterical neuroses, a long used exclusively female diagnosis. What year do we think this diagnosis was potentially removed from the Diagnostic and Statistical Manual of Mental Disorders? 1, 2, 3, 4, 3. It was 1980. And not until 1980 that this stopped being a valid diagnosis. And hysteria itself comes from the Greek word for uterus and considered a nervous stress disorder that was initially coined somewhere around 1900 BC. Been used up until 1980 with varying definitions of what hysteria is, but it's evolved over time. So later, it was thought to be a nervous stress disorder caused by starvation or displacement of the uterus. So too long without having a baby in your uterus could cause craziness. And then slowly over the next thousands of years, then considered demonic possession, part of why we had the Salem witch trials, and now hypothesized actually that many, like by many different reputable medical sources, that many women diagnosed with hysteria might have actually been suffering from the autoimmune disease endometriosis based on symptoms and reports and case studies and whatnot, which is actually a full body inflammatory autoimmune disease that leads to growth of uterine tissue outside the uterus, all throughout the body, gluing, fusing organs together, and even growing as far as the human brain. So, maybe they weren't totally wrong about the uterus affecting the brain health, just a little off target. So one of our last examples, heart disease. This is one area of research that became really heavily studied in the late 20th century. And the data determined at this point still determines our modern day first line approaches and standards of care. So one of these studies, very large scale, 22,000 participants. What percent do we think were female participants in this study? Okay. It is 0. Yeah. So therefore, no surprise today that early detection of heart attack is often missed in women, and only 42% of cardiologists self-reported feeling well prepared to assess heart disease in women. This is current data. And this is compared with only 22% of primary care physicians. So when you compare this to the percentage of women in the US currently being treated for hypertension 18 and older, it is almost 50%. So this is a pretty staggeringly concerning statistic. We then see what happens when they use sex-specific criteria for diagnostic accuracy. And in women, accuracy increased by 42% versus 6% increase for the males. So pretty staggering in my opinion. All right, this is getting into a little bit of what Dr. Ardil was talking about. So this is some examples to highlight the importance of doing sex-specific research, especially with complex diseases. So a lot of studies of MS have began to address more theories as to why women would develop at least autoimmune diseases more prevalently. So typical chromosomal females have 2 X chromosomes, although it is possible for women to have other chromosomal combinations, which is also important to study, but yeah. And so when you're born, we have 2 X chromosomes, one being randomly silenced because we only need the genes from one of those X chromosomes. But at some point, whether it's due to epigenetic factors, which is like environmental changes throughout your life that are influencing what genes are actually being expressed, sometimes we see genes on this silenced X chromosome become unsilenced. They're escaping and expressing, and that means we have kind of a double dose of some proteins being expressed, and a lot of these are involved in inflammatory pathways. So a lot of women with autoimmune diseases have these heightened immune responses already just from genetic influence. So scientists researching MS had identified one of these X inactivation escapee genes, and they wanted to see what would happen if they deleted this gene in mice with a mouse model of MS. So they did this in both male and female mice. And when they deleted that gene, it completely eliminated all the neuroinflammation due to MS only in the female mice. It had almost no effect in the male mice. Then they did the same thing with a drug. So mice with their model of MS gave this drug to male and female mice and found that this drug also almost completely eliminated neuroinflammation in the female mice and did virtually nothing in the male mice. If this, was research where we only classically used the male mice in the very beginning or male humans, we probably would have written these drugs off as being completely useless or would have thought that this plays no role in disease progression, but it's actually very relevant. So another interesting little piece of MS information, there is also hormones, which play a really big role in inflammation in general for women, especially like big hormonal changes like pregnancy. So doctors were noticing that a lot of women with MS will go into disease remission during pregnancy, and they didn't really know why this was. But there's one estrogen hormone produced by the placenta, and this is about the only time we have this hormone produced in meaningful quantities in our bodies. And so they did some drug trials on estriol, found out that it does have anti-inflammatory and neuroprotective properties. So they started giving this drug, well, not drug, started giving this hormone to women with MS who were not pregnant, in addition to their usual MS medications, and saw a significant decrease in disease relapses in the estriol group. And when they stopped this treatment, they saw all the areas in the brain with scarring and damage due to MS return and worsen. So when they put them back on this hormone, they saw that those inflammation levels once again decreased. And these were also on much, much lower doses than you experience during pregnancy. So they also kind of assumed that maybe usual higher doses, figuring out more research on doses might be helpful in making this even more effective. So now we're going to get into another disease, illness that is a very complex illness, has a lot of a lot of unknowns because this is a connective tissue disorder called Ehlers Danlos Syndrome. There are 13 or 14 recognized types right now under this one tree. And these have long been a kind of a mystery to the medical community. They're a group of genetic connective tissue disorders that impact collagen production. So they mainly cause things like joint instability and laxity, but also have a huge impact on a lot of other systems throughout the body that rely on connective tissue function, which we'll talk about is almost every system. So these conditions were thought to be mainly structural, meaning that loose connective tissue might cause things like joint issues, might cause some innate organ issues just because connective tissue is in your organs, but nothing going on in terms of inflammation or other types of dysregulation. And all these other types, besides this one I have circled in red, have a current known genetic marker. So anyone with these suspected conditions can go get genetic tested and find out 100% if they have them or not. But this one in red here at the bottom, hypermobile Ehlers Danlos syndrome, is the most common subtype. About 90% of cases are with hEDS. But this is the only one with no known genetic marker and also no known molecular marker, meaning it's only diagnosed based on what doctors are seeing clinically and kind of their opinion, because the diagnostic criteria right now is also getting reviewed because it's not very accurate. So this is also the only subtype where it seems to disproportionately impact women. And they have no idea why this is because the other conditions are all genetically inherited in a 50-50 split between genders because it has nothing to do with your sex chromosomes. And so they kind of assumed hEDS should be the same. But for some reason, in all of the published literature, we see that at least 70% of these cases are in women. So with hEDS, there is a theory right now that it's not purely a structural disorder. It could have an immune system activity dysregulation component, which might be similar to what we're seeing in autoimmune diseases in women. It might not be because of a chromosomal difference in X inactivation because we don't think that EDS is a sex chromosome gene, but could be due to hormonal influences, hormonal changes. There's a lot that goes on between the immune system and hormones and your nervous system, your gut health, all very interconnected. So yeah, this atypical pattern is the first red flag for hEDS. So firstly, this could be due to just statistical error and selection bias. So it could just be that in published literature, women are more likely to seek care in the medical system or are more likely to be study participants. It could be that they seemingly have more severe symptoms or more symptomatic cases of hEDS. So maybe it's still a 50-50 split, but women are severe enough that they are seeking more help. But yeah, this third theory is that it could have immune involvement. So two really big parts of this illness have to do with mast cells and the autonomic nervous system. So mast cells are a type of immune cell that we're going to get into a little bit more, and then your autonomic nervous system is kind of that, all of those nervous system functions you don't have to think about, things like blood, breathing, your stomach digesting at the right times, all those kinds of things. And this also includes hypermobility spectrum disorder, which is another condition that is considered like hEDS's sister condition. A lot of people are arguing they should be one because there's actually no meaningful differentiation between the two. Doctors just kind of decide which one you get diagnosed with based on their opinion. So, all right, so connective tissue. First, let's talk about what the role of connective tissue is so that you kind of have a good idea of how involved this is in all body systems. So usually the role of connective tissue is to provide connection, support between structures in your body, kind of binding everything together like a supportive, stretchy glue. There are many different types around the body, and this could be from within your joints, this is in your eyes, your digestive system, your nervous system, within your bones. It's everywhere. Even blood and lymphatic fluid themselves are connective tissue. So it's really a supporter of organs and cells. It transports nutrients, it transports waste. It works with our immune system, orchestrates tissue repair, helps us store fats. And so functional changes in this connective tissue structure, just at a molecular level, having these collagen impairments, can lead to the tissue being less elastic, less supportive. So we do see symptoms and changes that are due solely based on this functional difference, which is things like blood vessels maybe aren't able to actually perform as well because they don't have the normal support that they need to constrict or contract. Organs maybe aren't able to push food through, do their jobs as effectively, because they also don't have the normal support or transport systems that they need. So these changes in connective tissue cause a lot of symptoms just on their own, but they still don't explain all the symptoms and conditions that we see with hEDS. So we're going to talk about the way that hEDS impacts the rest of the body here. So comorbid conditions are basically the presence of two or more medical conditions in a single person that exist alongside the primary diagnosis. So basically any conditions that kind of develop either due to or in conjunction with your main illness. hEDS has a lot of comorbidities. The first large-scale research survey to ever be done on patients with hEDS and HSD was done very recently, last year. And they collected hugely large-scale data on hEDS and HSD patients, finally. And so their study found that people with hEDS, on average, reported 24 comorbid conditions with their primary diagnosis, and people with HSD reported an average of 17. And these here are just a few examples of literally hundreds of possibilities that come commonly with these illnesses. And then alongside this, symptoms vary a lot from person to person. But there's also a very high prevalence of mental health disorders and neurodiversity disorders with hEDS. So things like autism spectrum disorder, ADHD, OCD, nearly 50% of study participants reported one or more of these conditions. But in general, EDS has very widespread multi-systemic involvement, which makes these conditions really particularly difficult to identify under all these layers, because you can imagine these symptoms overlap constantly. But it leads them to be one of the most misunderstood and often very underdiagnosed disorders. So hEDS patients are commonly misdiagnosed with psychiatric conditions exclusively prior to diagnosis, because things like blood tests will look totally normal, MRI scans, those kinds of things will look totally normal. And after years of this, doctors finally go, it must be in your head, because we cannot see any evidence of what's happening. And so this leads to very significant diagnostic delays. In the same survey, they found that the average diagnostic delay for people with hEDS was 22.1 years, and for people with HSD, 17.5 years. So here in red, I have highlighted two that are so common that they are in up to 99% of hEDS patients. So they're basically just kind of an innate part of having this disorder. But again, they don't really know why these two conditions specifically would develop so frequently with a connective tissue disorder. So we're gonna get into a few reasons why we might be seeing these two conditions. This is kind of the trifecta. These conditions are called POTS and MCAS, which is postural orthostatic tachycardia syndrome and mast cell activation syndrome. So POTS is a type of autonomic nervous system dysfunction. It falls under a category called dysautonomia. And this condition is affected by the immune, or by the type of system that controls those like fight or flight responses, anything you normally don't have to think about. So it's pretty problematic when the autonomic nervous system is impacted, because it can really affect a lot of critical functions, especially things like venous blood flow for POTS specifically, because this is having to do with your blood vessels being unable to constrict and contract. When you stand, your body can't push blood up to your head like it normally should be able to. So people experience things like constant dizziness, vertigo, often passing out or nearly passing out. And just also we see a lot of generally dysregulated autonomic nervous system function in hEDS people, even if it's not specifically just POTS. So mast cell here, this is an immune condition impacting specifically one type of immune cell, mast cells. And these are the real leaders of inflammation. They're kind of those first line responders to any kind of detected invader in your body. So they contribute to things like allergens, the poison ivy hives, swelling of bee stings, but they can also be activated by things like medications, stress, temperature, just pressure. They can become very oversensitive in hEDS patients who develop mast cell. And this becomes very problematic and very hard to treat currently. This can also trigger vascular changes. So this could have an even worse effect on the problems that we're already seeing with things like blood pressure regulation. And it can also influence the development of depression, anxiety directly because it has a lot of influences on your gut health. And we'll talk a little bit more about your gut in relation to mental health just briefly. But also contributes to things like chronic pain because mast cells can directly cause increased sensitization to pain. And their activity is often regulated by the autonomic nervous system. And they can also feed back and determine how the autonomic nervous system is signaling everywhere else. So they kind of, once start this signaling pathway, they kind of get into this feedback loop of making each other worse. And now we're going to talk about one more big influence, well, a few more big influences on the function of these two systems, especially together, which is the gut, hormones, and stress as a factor. So some common massive triggers for hEDS symptoms worsening are changes in gut health, stress factors, and hormonal changes, which is pretty similar to what we see in patients with other immune diseases, which is interesting. And yeah, so that's the case for pretty much any other inflammatory disorder as well. But we also see a super high prevalence of gut involvement with hEDS and HSD patients, which second to the brain, the gut is the most diverse and complex nervous system in the body. It is connected to our central nervous system directly, and together they are both critical sensory organs that really detect, relay, integrate information about your internal and external environments. Don't know if you've really thought of your gut as a sensory organ very often, but it's seeing everything you put into your body, and it has to really be on alert for what your environment is like. So the gut serves to test and sample what's going on in our internal environment and communicate all this information directly back to our brain to let it know if there's something dangerous happening. There are also a lot of mast cells that live in your gut. So the gut function is impacted by signaling directly from the autonomic nervous system as well, which they connect directly by the vagus nerve and communicate constantly, and also by mast cells. So we now have three factors influencing each other. We have gut signaling, autonomic nervous system signaling, mast cell signaling, and all three are signaling to each other. We also have what's called the gut vascular barrier. So in your gut, usually we have these three barriers that really protect your gut from anything getting in that we don't actually want to absorb besides nutrients. But this permeability of this barrier can be altered specifically by inflammation signaling, including through activation of mast cells. So signaling from the autonomic nervous system can also weaken gut permeability or increase gut permeability. And this means that more things like allergens, toxins, pathogens can now enter our bloodstream. And this kind of causes a low-level inflammation all throughout the body. And this loop, again, just kind of continues to make itself worse if nothing is interrupting this cycle. Because the more pathogens and allergens are cycling through your body, the more that your immune system is going to be freaking out. The more your nervous system is going to be very highly influenced. And this also then makes things like your gut microbiome, which are the trillions of bacteria that live in our guts, to become also significantly dysregulated. A lot of the proper balance that we want to be maintained there can start to become altered. And that alone can weaken our gut permeability and the effectiveness of us of absorbing things like nutrients and having all the vitamins we need. And so this negative feedback loop can really be initiated and significantly worsened by things like stress, because stress can activate those mast cells. Stress causes signaling directly from the autonomic nervous system, because the autonomic nervous system is what is that initial stress responder, sends those signals to release stress hormones, and those stress hormones are then kicking everything else off. And this can lastly be modulated by hormone activity. So there are so many factors going into all of these things that we currently still don't understand. And you can imagine why this is then, I mean, sure, very hard to identify and treat, but also even the more important to be researching and studying these things, especially in relation to the influence of hormones. So on this next slide here, I just have a little pathway to kind of summarize what I just said, but visually, because I think that will be more helpful. So when we're in a state of long-term stress, our autonomic nervous system goes into this state of hyperarousal because it's really the key of stress being chronic. And this is going to keep sending those hormonal signals to things like your mast cells, which is going to cause them to be in this hyperactive state after long-term signaling. So meanwhile, during the same process, other immune cells are actually suppressed, which leaves the body in this kind of simultaneous state of hyperactivity and immune vulnerability, which is a pretty nightmare combo. And so not only is our gut then receiving signals directly from the autonomic nervous system, because we have those stress signals happening that are then directly impacting gut function, but we're also having mast cells now acting on the gut. We then have our potential allergens, toxins, pathogens, even just normal molecules, lots of things that we maybe still don't want to be seeping through our gut barrier too often. And those are then more able to permeate those barriers and cause even more significant low-lying inflammation in the body, because all of these things are just not actually being kept as separate as they should be. And this can even affect things like our brain, potentially allowing things to get to the brain. But this then feeds back into the stress cycle, because having more inflammation is going to keep your body in a state of stress. Again, sex hormones also have a direct impact on immune cell function, especially through things like pregnancy. Stress hormones during pregnancy will directly alter immune cell activity because we need our immune system to be at very specific levels in order for pregnancy to be successful, which could be why things like pregnancy and big hormone changes and puberty are such common triggers for either disease worsening or sometimes disease remission, but especially puberty is a very common disease trigger when people start to experience symptoms. But it's not all hopeless, because we do finally have some new evidence, a very recent study as of this year that actually found true evidence of immune dysregulation in hEDS, which is huge news, because some people in the medical community are just saying that, oh, being diagnosed with POTS and mast cell is just an easy out. Like, these patients are just very attracted to this theory because, you know, it can kind of explain that they're just having all these symptoms, but it's not really real. It's just a connective tissue disease. And that's a lot of medical providers that still believe that. So it's been really important to actually get some proper evidence as of 2026. So scientists were basically analyzing, they basically wanted to analyze how proteins were being produced and regulated in the bodies of healthy people versus people with hEDS. And they were able to identify over 35 proteins that were different between the two groups. So it could mean that some of these proteins are heightened in the hEDS group, maybe they're deficient, maybe we're seeing overactivity. But most of these proteins were found to be involved in immune system regulation, including regulation of mast cells. So these findings were in line with many symptoms seen in hEDS patients, but this isn't like a guaranteed causation. It's unclear if these proteins are exactly responsible for a certain set of symptoms, but they could definitely be involved in immune system impairment, blood coagulation differences, abnormal mast cell activation, autonomic dysregulation, allergic symptoms, dermatologic symptoms, and gastrointestinal symptoms, all seen in hEDS. They also found some differences in the innate immune system response that could be evidence as to why hEDS patients seem to appear more immunosuppressed as opposed to patients, or as opposed to the general public, because it doesn't really make sense to doctors why people with a connective tissue disorder would be more susceptible to bacteria and viruses, but this could provide evidence as to why. And this is an incredibly important, at least first step for validating patients, but also potentially coming closer to understanding why this condition could disproportionately impact women and why it might be so complex and multisystemic. Lastly, I'm throwing this in for fun because it's very interesting. So GLP-1s are a natural hormone that's produced in your gut, and these typically regulate blood sugar and appetite. But you might have heard a lot about GLP-1s because a synthetic version has now been developed to be used as a weight loss agent, and it's very effective. But there's also a high prevalence of mast cell disorder in people with metabolic diseases and obesity, such as type 2 diabetes. And obesity and type 2 diabetes are both inflammatory diseases. Obesity alone is considered an inflammatory disease. It has a lot of inflammatory effects. And so a lot of doctors that were treating patients with either type 2 diabetes and or obesity and MCAS were putting patients on GLP-1s for weight loss, but started to see really drastic reductions in their mast cell symptoms, pretty dramatically as well, because this would happen within like 24 hours to multiple days of being on these medications. So we do know that mast cells have GLP-1 receptors on them, which means that this hormone molecule can bind to a mast cell and impact its function. So far, GLP-1s seem to actually be exhibiting a significant anti-inflammatory effect on mast cell activation, but very unclear why in terms of scientists. They just know it seems to be working. So the very first study was released on this subject, looking into specifically GLP-1s with mast cell patients exclusively. This was varying age study, people from very young to in their 70s. And this was also 89% female study. And they started them on very low doses of GLP-1s, only about 10% of the dose used for weight loss. And 89% of those patients demonstrated really significant clinical benefits within 24 hours or days. They also, in the study, listed a bunch of case studies of specific patients. And like they spoke of one woman, I think in her 60s, who had such severe fatigue from mast cell, which can happen a lot, other symptoms like migraine, and was just so debilitated by this that she hadn't been able to leave her house for months. She couldn't do things like walk around the block or go grocery shopping. But she was started on these, and within a few days, she was able to go out, walk, grocery shop, do things she hadn't been able to do in years. So patients saw in general reductions in things like fatigue, migraines, allergic reactions. And so providers are starting to prescribe this off-label specifically for treatment-resistant mast cell patients. Because it's off-label, they don't want to just start giving this to everyone, but there are a lot of people whose lives are completely debilitated by this, and this is providing a good potential second option. All right, this is just my little summary slide, but yeah, I hope hEDS has shown you a good example of a condition that's been very misunderstood, complex, and predominantly impacts women. And it's been very difficult to interpret in the past, but our research fields now have more and more tools to investigate these kinds of multi-system diseases. So maybe we can finally understand why women are so much more likely to develop complex health conditions. And I hope going forward, we can invest more in women's health research, particularly in EDS research. It's a rough time for that right now, but hopefully somewhere someone is. Because these conditions have a truly massive impact on quality of life. They have a lot of complications that come with them that can be life-shortening or life-threatening. And the hEDS diagnostic criteria has long been considered too strict and or focusing on a lot of the wrong factors because it wasn't built on evidence from research. It was just built on, well, I'm a doctor and I tend to see that these people have a lot of joint instability, so I guess that's one main factor. And the things that built the criteria were kind of a random amalgamation of things different doctors had noticed, which is the best we could do at that time. But we can do a lot better now. And luckily, they are actually reviewing and releasing a new diagnostic criteria in December of this year that will hopefully include all of the patients that doctors are currently seeing who have all these issues and clearly have the same things going on, but currently don't qualify for the diagnosis, which is a big treatment barrier, obviously. So we're seeing a lot of strides being made. I'm very hopeful that we'll see a lot of new research coming out about this disease and others. And I hope in the future, we can hopefully leave fewer patients falling through the cracks of our medical system. Thank you for coming. Yes, Abby.
I have two questions.